partner in Raja Darryl Loh, and as you may know, we use panel law firms to assist members in country in a variety of ways, and as part of the large team to support you when needed. We're very grateful to Eileen for joining us. She in fact does a lot of cases for our medical colleagues as well within MPS, and she provides fantastic support, her and her team within country, and we're very grateful that you can join us. Thank you, Eileen. Now, pre-COVID, I would have been traveling at this time, and the plan was to be in Asia. I'm sorry I've missed the opportunity to have met with some of you again, and also to meet some new members. This is an incredibly challenging time, and as we can see, whilst we may have periods of low incidence, this virus may pose a threat for a long time to come. And naturally, I wish you all safe and well. Members of dental protection around the world would have faced same challenges of returning to work and creating a safe environment for everyone. The way we work and the procedures we carry out make the dental practice an almost perfect breeding ground for the spread of the virus, and we're having to face new ethical and legal challenges as we do so. Tonight, we will address many of the key issues and trying to answer as many of the questions you submit during the webinar as we can. The dental profession across the world has had to react and adapt very quickly to the pandemic, and the uncertainty attached to the changes we have had to implement has overwhelmed many of us, and that uncertainty has been the driver for the content of this presentation. Now, just a reminder of who Dental Protection are. We're the world's leading protection organization for dentists and dental care professionals with 68,000 members worldwide, and we're a non-profit organization. Please be aware of what your membership entitles you to, because there is much there to be of benefit for you, which is all available. And our philosophy is to support safe practice in dentistry by helping avert problems in the very first instance. Now, it's our intention to run the webinar for about 50 minutes to allow some time for questions at the end. We'll see how we go. If you have any questions during the presentation, you can send them to us via the question and answer box, which hopefully you can see at the bottom of your screen, and we'll discuss these at the end. We're awaiting approval from Malaysia Dental Association for the CPD, and once the webinar is over, you will receive an email asking you to provide feedback and complete your feedback, and please forward in, and we'll take the necessary steps to sort that out. So the key issues we want to focus on tonight are consent for treatment, and separately the use of disclaimers as a tool to protect you from a patient who wants to sue you for transmission of the virus. Very interesting area, that. And taking that theme forward, we will discuss the potential threat of litigation and the potential consequences if you are found to have negligently allowed transmission of the virus in your practice. Dental associations in many countries, just like MDA have shown real leadership through the pandemic and have overseen and supported the development and publication of professional guidance on clinical protocols. Also, government have determined what steps and actions we should take and should not take. What are the consequences if these rules are ignored or inadvertently broken? We will also look whether we'll see more claims and dental council matters arising during and as a result of the pandemic. Claims may take some time to come through, but we may see an increase in dental council cases or complaints where perhaps people have been saying, I've lost a tooth because it wasn't treated correctly during or even prior to, and as a consequence then I've lost the tooth. And we're seeing these issues arising in many of our countries in which we work. We will also explain the ethical rules supporting the use of teledentistry during the pandemic. And finally, we will discuss some of the key questions around ethical patient management which have arisen in relation to COVID-19. So to start with consent, this slide is just a memory jolt really, and highlights the three key components of the consent process commonly called shared decision making. Information. This speaks to the disclosure of relevant information by the clinician, as well as establishing the concerns and preferences of the individual patient. This is a two-way process. Capacity, the patient's ability to understand the information and to appreciate the consequences of their decision. This is the point in the consent process where they cognitively process the information and where you check their understanding. And the third element, the voluntariness, patients' right to come to a decision freely without force, coercion, or manipulation. Now, consent is not a tick or a signature, it's an exchange of information. There is a power and knowledge imbalance in the relationship, and the process of obtaining consent requires you to provide and indeed receive information. Our first job is to listen to the patient. That is active listening without interrupting them, which is not always easy in a busy clinic. Studies show that clinicians are not necessarily great listeners, although we are great interrupters. And as we often want to get on with doing and the fixing, particularly if the patient is in pain or if we have other patients backed up in the waiting room. When we want them to stop talking, we have probably already switched off our listening antenna. This can unwittingly undermine the quality of the information sharing and our ability to obtain valid consent. So we know communication is a two-way process, but when you look like you are dressed to handle nuclear waste rather than undertake an examination, things become a bit more challenging. Before we even get to treatment, the first decision a patient will probably make is about attending. Is it safe? You're unlikely to be part of this conversation, but you need to know about it and to be alert. Things can go wrong if your team is not properly prepared. If the patient expresses a reluctance to come to the practice for a face-to-face assessment, and where there is clearly enough in the remote history to suggest that they should, then the practice must very quickly undertake an assessment of that decision and weigh it against the potentially adverse consequences of non-attendance. In short, you or your frontline staff must be aware of the possibility that a patient may talk themselves out of attending for treatment they need, and they need to understand the dental and health consequences of not attending. The fact that this discussion has taken place must be recorded. This additional admin burden may seem like overkill. However, there are cases where a patient has successfully litigated, having been given incorrect triage advice. COVID restrictions place an increased responsibility on those carrying out remote triage, and you must make sure your staff have been appropriately trained on and are not delegated responsibilities for which they are not qualified. Now, the law requires you to discuss all the usual options and the risks for the treatment of a patient's condition, whether that treatment is available or not. For example, you may be unable to undertake root canal treatment because you've run out of rubber dam. But if you fail to mention this as an option for the patient with pulpitis or periapical periodontitis and offer only an extraction, then you would have failed to obtain informed consent for the extraction. So identify the patient's preferred option. Then we have to discuss whether that preferred option is available. The availability of normal treatments may be constrained by levels of restriction or shortages of PPE. And of course, what we need to realize, we may be in a fluctuating situation given the levels of virus and the status declared. So at this point, I want to mention aerosol generating procedures, AGPs, and how the way information presented about AGPs might inadvertently influence a patient's treatment decision. Until the evidence base gives us proper, robust scientific evidence, we are all exercising caution in the provision of AGPs. There is restriction on the AGP serves the public interest in lowering the potential for virus transmission, but the risks that the Malaysian guidance seeks to mitigate are not risks that apply to the patient having the AGP. Arguably, then, the increased infection control protocols and PPE do not necessarily protect that patient undergoing the AGP, and it would then be a failure in the consent process if a patient postponed treatment or selected a lower COVID risk treatment to avoid AGP in the belief that their choice somehow lowered the COVID risk to them personally. We need to be very clear about why we are dressed like nuclear physicists and look completely different from the last time your patient came to see you. It's not normal and certainly not dentistry as we and our patients know it. You therefore need to separate out the influence of availability, what treatments you can actually provide that day, in the patient's treatment decision, as this could undermine the voluntariness of the consent process. Now, as mentioned before in previous webinars, a signature may be regarded as good practice, but in isolation has limited benefits. The records need to reflect the consent process in that the information has been provided to the patient which they have considered and understood, but essentially records, not signatures. So essentially it's records, not the signature. So how do practices deal with consent forms, and can they be signed online, is something that we're often asked. Well, consent is a very wide topic and would be a webinar in itself, but with regard to a telephone conversation, it would be important to follow the general principles of consent. Inform the patient of your findings, clinical opinion. This is for a telephone triage, for example. Inform the patient of the reasonable treatment options in the circumstances, along with the risks and benefits, including the risk of no treatment at all. It may be appropriate in certain circumstances to inform the patient that the only reasonable treatment options at this time are an extraction or no treatment at all. Allow patients time to make a decision and advise them of any potential consequences if the treatment was not carried out. So good detailed records of the consent discussion should be made, including what the options were and why, along with the indication that the patient understood and agreed to proceed. In relation to consent forms, apart from areas such as sedation and general anesthetics, there is no real specific requirement for consent forms to be used. It is important to note that consent forms are not a replacement for the consent process, but may be a helpful adjunct. More important is a contemporaneous note written at the time in the records indicating the consent discussion, as I've previously discussed. Consent forms can be used in providing additional information for a patient to consider, and you could ask a patient to confirm by email, for example, that they have read the information, but this in itself would not be evidence of consent. And I bring up a slide now that is obviously from Australia, but with so many things now different in the delivery of care, it's easy to forget or to cut corners in our usual routine. And the key message about consent is that COVID hasn't changed anything. These are the key questions a patient needs to be able to answer at the decision-making point in the process. Your job or our job is to make sure that they have sufficient information to answer all of these questions satisfactorily. Choosing wisely is part of a global initiative to improve the conversation between clinician and patient throughout healthcare, in specifically the consent process. And it gives you a short and useful checklist to fall back on when we need a reminder. Now, in terms of disclaimers, we've been asked about disclaimers by dentists all over the world. The idea of the disclaimer is a means of transferring the risk and responsibility for virus transmission from the dentist to the patient and somehow giving yourself immunity to a potential prosecution or litigation in the event that a patient claims such an event occurred. However, there are significant issues to explore here. And Eileen, if you'd be so very kind as to take those forward, that would be great. Thank you.
Thanks, James. It's lovely to talk to everyone. It's about over 8 o'clock in the evening in Malaysia now. It feels very cozy somehow to speak to everyone late at night. I can imagine all the participants in their pajamas and their sarongs and all that, and watching us as we unfold, I think, the dental legal risks of practicing during COVID-19. Now, on the issue of disclaimers, we get asked this very often, James, and the question that has been thrown at me by James, and I suspect someone threw that at him first, is that given there is a theoretical risk of transmission, would a disclaimer protect me from a patient bringing a claim in the future? And can I be sued if a patient catches COVID-19 during a visit to the practice? I'm going to break this question up. First question I'm going to answer is, will a disclaimer protect me from being sued? The answer is absolutely not. Think about it. How will it protect anybody from being sued? Being sued means basically someone filing a writ of summons or summons in court. You can't stop that from happening. Everybody has the right to file that writ of summons or summons in court. Doesn't matter what disclaimer you may have in your practice. The second question I wish to answer is, can I be sued? Yes, of course you can. So that, I think, is the simple simple answers to the questions that is being posed. And if I move on the issue of disclaimers, My concern, James, is that very often that disclaimer may give the practitioner that false sense of bravado, that because I have a disclaimer and someone has signed off that they agree they won't sue me, I can sort of undertake my practice with perhaps less caution. And this is perhaps what we don't want to happen. Now, disclaimers are in fact at risk of being invalidated, as they may be regarded as unfair, unconscionable, and or against public policy. Now, if you want law, we are looking at Section 29 of the Contracts Act. The idea is that the law really, I think, is slow to uphold a term or a provision that extinguishes someone's right to recourse. In other words, if I have been injured, the law should allow me that right to claim for my loss or injury. The law thinks it is unconscionable to stop someone from claiming for injuries, for example. Now, a recent decision decided by the federal court illustrates this point quite nicely. It's a banking case, but it's still applicable. It's the case of CIMB Bank Berhad against Anthony Lawrence. Basically, plaintiffs obtained a loan, the bank missed a payment, they filed a claim against the bank for breach of the loan agreement and negligence and breach of fiduciary duties. And the exclusion clause or disclaimer that the bank tried to rely on is on my next slide, James, if you don't mind. Thank you. It's basically notwithstanding anything to the contrary, in no event will the measure of damages payable by the bank to the borrower for any loss or damage incurred by the borrower include, nor will the bank be liable for any amount, so on and so forth. So when we look at, I mean, people have argued perhaps this clause doesn't really completely exclude all damages, but some people think otherwise. At the end of the day, the clause, when it was an exclusion clause, which sought to expressly exclude the bank's liability in respect of loss and or damage suffered, regardless of the cause of action. So here, for example, in most cases involving dentists, the cause of action would probably be in negligence or a breach of contract. And the bank was trying to exclude all claims in respect of all causes of action. And what did the federal court say? Next slide, please, James. The federal court in that case recognized that there was patent unfairness and injustice. There you go. Denying the plaintiff their claim or rights against the defendant. The court recognized, of course, there is freedom of contract, but it felt it was unconscionable on the part of the bank to seek refuge behind the exclusion clause. Now, I'm going to take a step back. One of the things the court did look at is the inequality of bargaining power. So, for example, when there's a bank and a customer, I think you and I, more often than not, are customers, we probably just sign whatever the bank gives us to sign, really no say in the matter. In some respects, the court may view a contract excluding a liability or disclaiming liability by a dentist in the same sort of vein. There is inequality of power. If I'm sort of having terrible toothache, I go to a dentist, please remove it now. Dentist says, please sign this disclaimer. Do I really have a choice? I'll probably sign it. I'm putting it in very simplistic terms, but that inequality of bargaining power is likely, let's put it that way, to lead to the invalidation of a disclaimer. So if I could move on just to my cartoon, the jury, ladies and gentlemen, is likely to disregard a disclaimer.
Thank you, Eileen.
To the end of that question.
Thank you very much. And so, yeah, the disclaimer issue is a common inquiry of the last few weeks. And in some cases been the cause of sort of interprofessional disputes, with one side believing firmly that obtaining a signature from a patient on such a form was effective and others not. And clearly there's an issue there. And I totally understand the thinking behind this. However, you know, as you say, please be aware you cannot contract out your duty of care, nor can a patient consent to negligence. So little value. And on the contrary, that, you know, the use of disclaimer may well plant the seeds of doubt into the mind of a patient who catches COVID, that the source of the infection was in fact the dental practice, the very thing you're trying to avoid. So if you want to reduce the possibility of a patient bringing a claim for transmission of the virus, then I think you're far more likely to achieve this by reassuring patients that dentists have always had to follow the strictest infection control protocols. And you may also wish to highlight additional COVID-related protocols in practice, if there's follow time, social distancing measures, all of the steps that are taken. And this reinforces the message that your practice is a safe environment rather than the potentially risky one, which is implied by the disclaimer. Perhaps then the second most common question we have been asked is whether we would provide an indemnity if a patient actually attempted to sue for transmission where guidance hadn't been followed. The first thing I want to say is that COVID-19 has not placed any restrictions on the scope of indemnity, and your right to request assistance from MPS Dental Protection is unaffected. Access to indemnity does not provide immunity, however, in the event of a patient wishing to sue or reporting into the MDC. That still carries on, because we have had some saying, "Oh, no, if I have the indemnity, then I'm safe." Well, we can't stop patients taking action, or the complaint being made to the Malaysian Dental Council. But we do need to distinguish the defensibility of a dentist in the following scenarios. So the dentist, in providing care, has followed guidance and correct use of PPE. They also implemented social distancing protocols and had used remote channels of communication to identify and isolate patients at risk. Great, all being followed. The second scenario is completely different, where a dentist deliberately chooses not to follow the guidance, fails to use PPE, putting themselves, their staff and their patients and the wider population at risk of transmission. Such behaviour may well be considered deliberately reckless and irresponsible, and would normally invalidate the terms of any insurance. We're not an insurance member, but if such a situation arose with the dental protection member, then whilst being indefensibly legally, it would also raise questions about the level of support a member should receive from dental protection as it amounts to the individual's personal conduct. So we would expect people to be following the guidance, and the Malaysian Dental Council would be deeply concerned if their investigation of a complaint alleged such behaviour. The issue of safety is at the top of every agenda, and there'll be little tolerance, I'm sure, by the regulators and others in terms of compliance at this present time. If the transmission takes place in the practice but outside the treatment room, then your public liability should be approached. And if a member of staff contracts COVID through a failure to implement the necessary safety measures, then this would fall to the employer's liability insurance. So if it arises within the format of clinical negligence due to problems in the surgery, then of course you can approach us. So then what about our own infection status and that of our staff? What happens if we test positive? And again, Eileen, if I might bring you in on that point.
Sure. Throw it at me, James. Throw it at me.
Catch. There you go.
Okay, the question posed is, what do I do? What do I have to do if I test positive or if one of my staff tests positive? Goodness gracious, if you test positive, stop treating patients, go and get treatment, and isolate yourself and so on and so forth. So in Malaysia, there has been a lot of guidelines issued, multiple guidelines issued, some specifically for dentistry. So I've listed it out in my slides here. And of course, we know that the Malaysian Dental Council itself already has existing infectious control guidelines. So reading it all together, these guidelines are updated from time to time. So you just have to make sure you're up to date. And really the way to do is go to the MOH website. At the end of the day, it is the duty of the management or sometimes the head of department of a particular organization to ensure the safety and health of their staff and workers. So what you should do, basically, if you're in management, you're head of department, you're in charge, you have to know what to do and you have to know the latest guidelines. If someone is ill, isolate them and send them off for treatment. And then I think the ministry will then kick in and they will do contact tracing. If there are signs and symptoms are detected, don't allow them to come back to work, for example. Monitor them, send them for testing, and only allow them to come back to work once they're cleared by a medical officer. I think this applies to everyone, including my own practice, for example. If I move on to the next slide, again, the head of department has particular duties, including making sure that everyone has a safe working environment. That's absolutely vital. That really is it, James. I think at the end of the day, let's keep abreast with the recent or most or the latest, we call it SOPs, so standard operating procedures and guidelines. Visit the Ministry of Health website. They update it from time to time depending on what stage of the movement control order we are in. But I think it is incumbent upon the head of department or the owner of a particular clinic to ensure the health and safety of the staff, and everyone has a healthy and safe working environment to work in. That's important.
Yeah, and I think it is such a fast-moving, or has been a fast-moving environment, that you really got to keep up to speed with the rules by which we're playing, because it's those rules at which you'll be held accountable. And it may be worth just making a record of the the date and the basis, what the rules were at that time, which were applicable, so you're married to them should there be any need to produce evidence of that. And the current situation here, we talked about Malaysia. Dental Association had been very helpful in putting out information, and indeed this is as such. So we've got rules and we've got guidance. Now, with things changing, people will fall foul, whether it's inadvertently or with intention. So the next question really is, well, what happens to me if I don't follow the rules? And I think there's maybe legal and regulatory, and if I might bring you in, Eileen, again to
well, there you go.
Yeah.
It says it all.
Yeah.
We've even had our deputy health minister being fined. I mean, quite rightly so. The authorities have been extremely strict in enforcing, the provisions of the Act and the Movement Control Order and the regulations that have been gazetted. So I think it doesn't matter, be it a dentist, be it a lawyer, be it a minister, if we are non-compliant, we're exposed to, number one, criminal prosecution under the Prevention and Control Infectious Disease Act. That will come with it, usually fines, although there is also a jail period. Now, but if one is a practicing dentist, then of course we should also be concerned about dental counsel inquiries, because a criminal conviction may lead to a dental inquiry or complaint being placed by the authorities to the dental counsel, and then you've got another set of problems. And if, for example, it's related back to your clinic or your practice, then even more so, I think, if the breach, for example, is relatable to your practice as opposed to you going jogging, perhaps. And of course, the civil claim, I mean, it's I think the potential of someone suing you for not following particular regulations and hence injuring someone is there. Probably the likelihood is lower, I feel, because I don't think people are generally in the mood to sue people for COVID-19 related issues at the moment. But I think the main thing will be that criminal prosecution, and for a practicing dentist, followed by a dental counsel inquiry. Those are the two main things we need to look out for.
And we'd seen in other countries as well that I've witnessed, there's been an upsurge of support and respect for the healthcare professions, particularly obviously the medics and the nurses who have been doing some significant, heroic roles in the midst of all of this, particularly where there's been high incidence of events. And we wondered, whether that would have a knock-on effect in terms of the claims, complaints, people being driven to challenge when they see what actually the guys are doing out on the front lines. And I think it's perhaps gone quiet, but we'll see in the future whether those, whether there will be something. And this is an area that we'll explore now, and in terms of dental, with Lou. If I could bring you in, Lou, and perhaps just to discuss, about might we see an upsurge in matters arising for our colleagues.
Oh, thanks, James. Yeah, it's certainly a very interesting question, and obviously taking into account the unprecedented situation the dental profession is facing, it is difficult to predict exactly what the impact on claims experience will be. Obviously, for a period of time, many of you will have been undertaking only a fraction of the work you would usually provide. Therefore, the risk of claims arising from actual treatment or higher risk procedures will be significantly reduced. What we may see, however, is complaints and claims arising from patients who perhaps believe they weren't given the correct advice or didn't receive a referral for emergency treatment, for example, when they felt it was needed. In order to protect yourselves and the environment, it's therefore very important to make sure your patients receive clear information about how to seek care and advice, including emergency care. And this make sure this is clearly recorded in details. Make sure all patient contact is noted within the records, including the details of your assessments, diagnosis, and all the advice and discussions that you've provided to that patient, that you've had with that patient. Ensure that your advice, as Eileen said, is consistent with the current local guidance. Obviously, that's very important, again, noting that down. We also know that especially emergency treatment can carry a different set of risks when treating unknown patients to the practice who may be new to the practice. So you have an absence of any historic records for the patient in your clinic. So we therefore may anticipate some claims arising from this environment also. Set against all of this, in the economic downturns we've previously witnessed, an increase in claims. Therefore, in the longer term, we may anticipate a rebound of claims due to the financial impact the pandemic has on the economy. One potential risk area may be from patients who end up requiring emergency treatment in a referral centre or hospital setting, who then questions whether the need for this treatment could have been avoided. We will obviously constantly be reviewing our data to look at the impact of the pandemic and share these insights with you. Naturally, should you receive any challenges from a patient regarding their care, our international team of Dentolegal consultants will be very happy to provide the necessary support to you. The second point I wanted to mention is around, is there a risk of an increase in litigation given the restrictions placed on routine dental care by the lockdown? So the answer here is yes, there is a risk from the patient group who are unable to access care or who had treatment during the lockdown without access to the full services normally available, who might, for example, not have been contemplating an extraction when they presented with an emergency. There are a number of steps you can take to reduce this risk. As many of you will be aware, in order to be successful in bringing a claim in negligence, the patient must firstly show that the defendant, which in our case is obviously the dentist, owed them a duty of care, and then it was shown that the defendant had then breached that duty of care, following which the claimant, the patient, had suffered quantifiable harm as a result of this. So in legal terms, this is known as causation. Let us look at these components in turn a little bit more closely. So firstly, duty of care. It is obvious that a duty of care exists when you have offered treatment or advice on a face-to-face basis, or prescribed antibiotics or analgesics, for example, to the patient. However, you will also have established a duty of care by triaging that patient, even if that only resulted in verbal advice being given, for example, during your telephone assessment, as would occur in teledentistry. So when discussing a breach of duty, the fundamental principle is that the onus of proof is on the patient to show that the care provided by the dentist fell below the required standard. So the basic standard is that of a reasonable person in the circumstances of the practitioner, and I emphasize the word circumstances. So in other words, a professional person must meet the standard of competence of the reasonable professional doing his job. So the COVID-19 situation has led to the introduction of guidelines that may have severely limited the way in which you work and the range of treatment options that are available at any particular time. So this has a significant bearing on what would be considered reasonable in the circumstances. So a course of action that might have been reasonable pre-COVID may not be reasonable under the restrictions or even at all possible at that time. So therefore, it's unlikely that you will be found to be in breach of your duty of care by following nationally determined guidelines, as you were acted no differently from any other reasonable person would have acted in your position. So the types of harm that might be alleged include extraction of a tooth, perhaps that would have been otherwise saved following endodontic treatment, assuming of course that tooth could have been predictably restored once the root treatment was completed. Or for example, perhaps a drift of teeth or need for endodontic treatment arising from an extended period of temporization, as it may not have been possible to fit the final definitive restorations. Another concern has been the continued resorption of alveolar bone following extraction of teeth and the placement of implant fixtures. So the most likely or common patient concern is where teeth have been lost and where it is alleged they could have been saved potentially. So solicitors are unlikely to be successful in arguing the breach in duty occurred during the restrictions for the reasons we've already discussed. What they may do is rewind the clock, trace this history of that tooth pre-COVID. So they may find that tooth has been symptomatic on and off for some time and argue that had a more decisive treatment option or treatment such as endodontic treatment had been provided at the outset before COVID restrictions came into place, then the tooth would not have been lost. So regarding other problems that may be caused by a delay in providing care, what is important is now that you gauge the COVID situation moving forwards and be able to prioritise such cases to perhaps see them sooner rather than later, should you have been forced to stop practicing or reduce practice for any length of time, or if this again kind of occurs in the future, dependent on infection rates. For those of you taking reasonable steps to be able to continue in practice, it's obviously essential to ensure all the necessary risk assessments are carried out alongside developing operating protocols and sourcing appropriate PPE from suppliers. So of course, it's a lot of speculation, views on the situation so far, which says what we've come to. Only time will tell. I hope I've been able to offer just some reassurance in claims where it is alleged that there has been a breach in duty, where in fact all you were doing was only following the guidelines.
Okay.
So if I can move on to the subject of teledentistry, you may find that patients do not want to come to the surgery at the moment for a number of reasons. Obviously, the fear of kind of going outside a little bit more, reducing leaving houses, or they may be in vulnerable risk groups, so they wish to obviously receive advice over the telephone. So during the pandemic, obviously digital channels for non-face-to-face communication has become an excellent way of undertaking a COVID assessment and following up on outcomes with vulnerable individuals. The risk is that both we as dentists ourselves and patients can sometimes try to push the boundaries and cut corners where a diagnosis and treatment plan clearly needs a face-to-face assessment. So the duty of care begins the moment you provide an assessment and advice online, and it does come with certain limitations. There is then a risk attached to remote prescribing of medication or antimicrobials, analgesics, particularly where there is no previous relationship with the patient and they are unknown to the practice, and you have no access to a proper medical history perhaps. Then there's an issue of record keeping and the processing and storage of that data. It does become important, and you need to ensure it complies with local guidance. What would you do if the patient sends an image of their mouth? Would you delete it? Would you save it? Is it part of the record? These are the kinds of things that you need to be thinking about if you're providing advice over the telephone. Digital access means there are no international boundaries also, so are you aware of the patient's location? If you do give advice to patients outside of Malaysia, what happens if you are not registered for that country that the patient is in? There's clearly going to be changes in the way we all interact with our patients remotely. Right now, us dentists face significant challenges and perhaps not enough solutions at the moment, with many aspects to consider. Many aspects you need to carefully consider if you choose to provide these services. So it's fair to say we found ourselves facing very difficult, challenging ethical scenarios. It's a little bit like this Rubik's Cube you see. So I want you to think of these ethical issues as the faces of the Rubik's Cube, where the faces can be twisted and turned. It obviously demonstrates the different ethical configurations that you can have. Each day, each and every patient brings a unique combination of ethical issues. So this represents the risk exposure at that particular time. So somebody once said, our wisdom is all mixed up. Well, at the moment, so is our risk during this pandemic. So the key is to be alert, don't be afraid to ask questions, ask advice, discuss with your colleagues, call us. Sometimes there's no easy answers, but we are here to support you through these difficult times. So just moving on again, I just wanted to touch upon patient expectations and the treatments at the clinic. So with the inevitable changes in the way in which patient care is delivered at the moment, how can patients' expectations be managed? So we all know things may be very different, potentially with new ways of working, which will mean considerable changes for our patients accessing care. So infection prevention and control is very different, as is social distancing, patient flow through the practice, and remote consultations, which we've just discussed. And triage play a large part in the patient's care. So it's really important to manage patient expectations, prepare them for the changes that have been implemented for their safety. The patient experience is going to be completely different, and remote consultations continue or can be a part of the patient journey. This provides you with a great opportunity to also manage the expectations from the outset. So there are various ways in which you can manage patient expectations and maintain confidence in the profession. Communication is going to be absolutely key. Prior to the patient's appointment, some clinics have taken the opportunity to advise patients what measures have been put in place for patient safety, what to expect when they attend for an appointment. This may perhaps include waiting outside the practice until being called in, answering some screening questions in relation to COVID symptoms, also having their temperatures taken on arrival using hand gel, etc., or even advice sometimes to not attend the practice without a pre-booked appointment, or potentially asking the patient to attend their appointment alone, with the exception of children or patient carers, if the clinic is not able to accommodate as many people, with an onus obviously now being on social distancing. You might want to consider updating your clinic website with your latest protocol, ensure there is clear signage displayed within the practice to direct the patients throughout. Obviously, each clinic will differ. I'm sure patients will appreciate being kept informed of current circumstances, just so they have a clear understanding of what to expect really, and if there are any potential limitations on the provision of some treatments at that particular time. And also keeping the patient informed of these changes in relation to the government advice, and obviously the change in infection rates as time moves on. Okay, so this slide here shows some questions we've been aware our clinicians are asking. So first, can I refuse to see a patient who is known to be shedding the COVID virus but has a dental emergency? So for a patient who is known to be infected with COVID, then yes, you can refuse to treat them. However, if the patient is in need of urgent dental treatment, you will obviously need to refer the patient urgently to a nearby government hospital to ensure they're able to access treatment in the correct clinical setting. This is especially important if there's potential life-saving treatment which may be provided, such as infection is closing an airway, or they're experiencing severe hemorrhage. In these circumstances, you would always be referring the patient on anyway, so perhaps this is not entirely different to your usual procedures. Second one, can I use lack of PPE as a reason not to see the patient who has an emergency? Again, the answer is yes. However, the reason for refusal needs to be recorded in the notes, and why you feel you are unable to safely provide treatment at that time. There can be difficulties in obtaining the necessary level of PPE, obviously at the moment required to provide treatment. So this may be something you will or may encounter. Moving on, we can perhaps just imagine a scenario where a patient has a diagnosis of COVID and has a dental emergency, or they've been in pain for some time to the point where they may try and hide the fact that they have been diagnosed with COVID. Can I pass this scenario over to you, Eileen, to further comment on, please?
Yes, of course. Thank you.
you.
So the question is, can I sue a patient? There seems to be a pattern here. I keep being asked whether you can sue or can be sued. But can I sue a patient if they attend a practice but don't inform us that they have COVID-19? Now, this is a bit of a sensitive issue, I think. The issue about patient honesty, isn't it? And sometimes perhaps patients or people feeling sort of compelled to sort of not disclose their true status. I actually am of the view that there is a duty of care owed by the patient or by anybody to others. You can't knowingly, I think, sort of infect or potentially infect others. And by not informing, I think there's potential of injury or infection to others. So if I look at that obligation, even under the Prevention and Control of Infectious Diseases Act, there's an obligation to notify. There's an obligation to notify authorities, and usually the authorities would then do their contact tracing and so on and so forth. So the obligation to notify and make known, I think, your status of being infected is already there. I can trace it back to this act. And of course, if you don't notify, it comes with it some penal consequences of being fined and so on and so forth. But at the end of the day, I think the obligation to notify that is contained in the provisions of the Prevention and Control of Infectious Diseases Act, and also we have also obligations in the Penal Code, I think, along the same lines, will, I think, also give rise to that civil duty to notify others, including, of course, a dental practitioner will be in close contact to his or her patient that this patient is in fact infected. So can you sue? The answer is probably yes, but should you sue is the question. Well, if you really want to. I'm not going to this evening, James, encourage people to start suing their patients. We are all in unprecedented times. But of course, at the end of the day, I hope that everyone will feel honest enough, I think, and not put anyone at unnecessary risk. So the answer is yes, you can if you really want to.
Yes, I think we have chatted before about the process of litigation, and normally it's the other way around. We're seeing it, the patient versus the practitioner. And when you look at the end of that process, which is adversarial and then falls driven by others, I think both parties look back with regret to the process, not just necessarily the practitioner or the team, because it's not a decent journey for the patient, and litigation is unpleasant, and really is a sort of last resort. In this situation, there would be, I think when you've got such an emotive and sort of catastrophic time, when people are seen in the press to be suing or seen to be taking aggressive steps, and does it do the long-term reputation much good?
Can I add, James? Sorry.
Sure, please.
I forgot, because I remember now. Louise was mentioning. Remember the elements of negligence or a breach of duty case. You have to have that breach of duty. I'm saying potentially that will be there if a patient doesn't inform you of his or her status. Then you have to have the cause and then the injury, right? So even if we accept that a patient then finds, you find yourself being infected by COVID-19 after treating a patient who has COVID-19 and failed to disclose that to you, I think evidentially you will probably still have a problem trying to prove that that patient who failed to disclose his or her status was the cause of your own infection. Unless you're in a bubble and you only see this particular patient at that time. We're all now going out in Malaysia, for coffee and so on and so forth. You could have gotten infected from anywhere.
Yeah, and I think that's the other way around as well, isn't it? So the patient saying, I got it from you, but they could have got them from anywhere. And we talked about, and we talked about the support, we provide if it was a claim in clinical negligence or a claim that it was in the waiting room. Those issues are, yes, we've set those apart, but in reality, this causation is going to be pretty impossible to show, you know, where did I catch COVID? I mean, we've had some medics already where patients are trying to bring actions against them because they've caught COVID. But was it on the bus or the train to go to see the doctor? Was it in the taxi? Was it walking past somebody in the street? Was it, you know, it's going to be so difficult that there may be a lot of litigation, but without any end result, without any real evidence. You know, people maybe, yeah. So I shall come back to Lou if we move forward onto that one.
Thank you. Yeah, I was just going to just cover a few points surrounding PPE. Actually, so we have received queries that dentists are concerned that they may be asked to work without appropriate PPE, and what should they do? So using the correct PPE for the particular clinical procedure you intend to provide has two purposes. So clearly you will be concerned to protect yourself from any risk of contracting COVID. At the same time, protecting yourself, you're protecting your patients from the potential onward transmission of the virus. This should be taken into account in your practice's standard operating procedure, which we've kind of mentioned earlier on. The guidance in all countries is entirely clear. You must use the appropriate PPE, should be properly fitted, and you should be trained in its use as well. So I can appreciate it's not easy to express your concerns in a situation such as this. So as mentioned, it may be that your clinic, like many at the moment, is struggling to get hold of PPE. So in the first instance, check your understanding of the correct level of PPE for each clinical circumstance. Are there other ways of making sure patients can get the care that they require? Can treatment be delayed, or can the patient be referred? Is that an option? If it's not possible for you to manage the situation satisfactorily, you should let your practice owner or employer know that you cannot undertake the treatment until the appropriate PPE is available to you. To continue on regardless would in any case put you at risk of challenge, and even if you are indemnified to carry out that planned treatment, even with dental protection standing by your side, it might not be possible to defend your actions. On the other hand, regulators such as Malaysian Dental Council are likely to accept that refusing to treat a patient when you consider it is not safe to do so is a matter of professional judgment, and it's unlikely that you would be challenged. Thanks, James.
Okay, thanks, Lou. And then in terms of sort of ethical decisions and being fair to ourselves, you know, when faced with the ethical dilemmas we are, sometimes we make poor choices on the spur of the moment, and afterwards we'll try and justify what we did, a form of situational ethics, and we need to sort of try and guard against that. I mean, never before have we been faced with ethical decision making that could potentially lead to the death of a patient if we get their management wrong, or even our own death and the loss of a business. Ethical decision making during the pandemic has such serious consequences, and no more is it only the patient's best interest that are paramount. Right now, we all need to focus on self-preservation as well. Self-sacrifice is the stuff of religion, Shakespearean dramas and stirring epic films. Self-sacrifice is not the stuff of frontline healthcare workers, and most of us joined the healthcare profession not to risk our own lives, but to save others. Guidance is there not as a punishment, it's there for safety and self-protection. Never before has risk management meant so much, and never before has our ethical decision-making had to take into account so many variables. The level of the virus, the incidence will change, so will the levels of alert. And we just need to keep up to date, up to speed with each and every one, and note that for our practice. So currently it's dentistry, but definitely not as we know it. Thank you. Now that brings the presentation to an end, and we will look at some questions that have come through on the Zoom platform, and we do have a couple of questions there. Now, one is, if I am a DPL member and one of my patients is tested positive for COVID, what should I do? What can DPL do to assist? Okay, Lou, would you want to take that one, and maybe we can bring Eileen as well. Let's chat over that one.
So if one of your patients is tested positive, obviously they need to follow, like Eileen mentions, the appropriate guidance to have treatment. We would obviously,
I think they're challenging. They're challenging us, aren't we? They're challenging. If the patient's caught it, then presumably the presumption in that question, I think, is that there's a challenge, isn't there? Professional challenge. That they've caught it from the practice. Yeah. Right.
So I mean, it's as Eileen kind of obviously mentioned as well. So it would very much depend upon you would provide the information to us. Your indemnity, like we say, does remain the same. So we would obviously look to support you in the circumstance. We'd obviously need to look about the specific situation, whether you had SOPs in the practice, what procedures you were following, if you were following local guidance, and then moving on from there, we would kind of obviously provide the appropriate level of support. Is that what?
Yeah, absolutely. James? Yeah, indeed I would, and I think it's important, to be comprehensive in coming to us and presenting the information. As Eileen's just said, it's probably very, very difficult to demonstrate that, if there was anything taken against. But we're here to help. We can provide local support through Eileen. Eileen, would you have anything more to add in relation to that?
I think in terms of the specific Ministry of Health guidelines, make sure, I think if you're a clinic owner, make sure you have it handy, quite frankly. You never know when this might strike, isn't it? So you need to be quite familiar, and you need to be familiar with the latest, because it is, like James mentioned just now, I think sort of, it keeps changing. I mean, not that it's changing, but I think they keep updating it, quite rightly so. So make sure you have the latest guideline. But the April 2021, if you look at guideline 6.21 and 6.22, it says very clearly what you need to do. But really, what you need to do, I think, if I just take it very, very sort of widely, you need to notify your sort of closest sort of COVID-19 health clinic or hospital. Notify if you have it, or definitely then the obligations on you to notify. If your patient has it, again, it does have very specific guidelines on what to do. It includes, for example, taking appropriate precautions, making sure that the rest of the patients are treated. They say treated as COVID-19 patient. I think what it means is, in a way, you have to be on alert, isn't it? You've had a COVID-19 patient on your premises, so you have to be on a high alert. I think making sure that everything is disinfected, everything is clean. Notify your nearest health clinic or COVID-19 hospital, and then I think make sure that whoever is in charge, I think liaises with the clinic and hospital, as in then they will do contact tracing, so on and so forth. I mean, those are generally what I think happens. But I think what is most important is keep updated. Have with you, if I were to give you practical advice, that latest, because they have one specifically for dentists and dental clinics. Have that handy, so that you can quickly look at, depending on what's happening to your practice. Is it a patient? Is it a staff? Is it yourself? Or is it just a person under investigation, for example? Different things will then kick in and be triggered. So make sure you just have it handy. That would probably be my best advice for tonight.
Great. And if it does come in the form of a legal challenge, then, as we've said, if there's a challenge that I've just been at your practice and I've caught COVID, is that public liability, or is it clinical negligence? If the claim was based in the fact that rather than social distancing and structure of the build of the practice, if there's been negligence in relation to cross-infection control within the surgery, then that's when that brings us into it, rather than public liability, which is the former. Maybe
cross-infection control procedures is also a guideline, a 2017 guideline. So have a look at that as well. We have guidelines on almost everything now. There you go.
Yeah, it is guideline time, I'm afraid, and following the rules of the game. It is, Probably take one more very quickly. Can a dentist refuse to treat a COVID-19 patient who has been discharged following COVID treatment? Now, see what you think, Eileen, but if the data that we currently have is that we've had someone who no longer therefore presents shedding virus, they're not shedding the virus, they post, then my take on that would be that those who are complained to Dental Council would take the view that that patient didn't currently represent a risk, therefore it would be difficult to justify with normal PPE, using appropriate PPE, it'd be difficult to justify a refusal to treat that patient. Eileen, would you have any other comments, or Lou, would you have any other comments on that?
You don't mind me jumping in, Lou? Is that okay?
No, go ahead, Eileen, go ahead.
It's okay. So the Malaysian Dental Council, the Code of Conduct has a very specific provision on refusal to treat. And it is, in a way, discriminatory, isn't it? To refuse to treat someone just because that person has had a communicable disease. For example, it may not be COVID-19, it could be any other kind of disease. So sort of past diseases, the stigma attached. I mean, I can sort of think about other diseases as well. So the whole idea is you can't, it's not professional, I suppose, let's put it that way, to discriminate unnecessarily. And they will look at it with stern eyes, let's put it that way. Yep.
Yeah, great. No, thank you. That's we agree, Lou. Is anything further to add, Lou?
Yeah, I was going to say, I mean, obviously, if they've had it for a certain period of time, they're discharged. Like you say, you'd expect them to be discharged to be non-shedding the virus at that point. So perhaps as your pre-COVID assessment, you might want to just ask those additional questions and kind of pop that within your record when they had it, how long they've been in, when they've been discharged, just to have those kind of reassurances there, really.
Good point. Yeah. Okay. Well, very much aware that it's into the evening now for Malaysia. Eileen, it's always a pleasure to speak to you, to see you, and thank you so much for coming to play such a great role in bringing this event. We're very grateful to you. Thank you as well, Lou. Thank you for those attending today. Please be aware of, as I said at the beginning, what dental protection can offer you. Go to the website, have a look at the other stuff we do provide through our PRISM, and keep an eye out for future events. We shall leave you to what's left of your evening, and Lou and I back on to casework. Come on, Lou. Back on to casework. Okay, so we'll say goodbye, and thank you also to Kim, our regional director, for hosting this in the Zoom platform. Thank you, everyone. And
thank you.
Good night.
Good night, everyone.
Pleasure.
Good night.
Bye.
Off to bed now. Back to work. Bye-bye.
Bye-bye.